So you bring up a good point that when you're thinking about, so you're in clinic, diabetes patient walks in, some really high proportion of the time, it's really a larger metabolic syndrome construct or challenge. And so you're having a patient visit. Who are the various folks for a typical patient now that you're, even within a closed system, that you're gonna have to coordinate to optimize therapy for that patient?
There's a lot. And again, I'm fortunate where I work in a system where I have access to that. But in many situations, they probably know what that ideal care team looks like, but they can't refer a patient to nutrition or can't refer a patient to a dietitian. So again, those are some of the things that, you know, we have that luxury of. We have a pool consult. We can send them to our own pool, you know, so those type of things don't exist everywhere. But it goes back to that team where that point that was made earlier. It's a lot of folks that have to touch that patient, from all the way from the person at the front desk booking that patient's appointment for the referrals that you made, because if that doesn't happen, just because you documented the referral doesn't mean that patient's going to have that eye exam or foot exam, all the way down to the pharmacist level, and then again, taking it beyond and outside of the hospital and the office, I think, is where a lot of the focus.
So interesting you say that then. So I keep imagining when my kindergartner went to school, we watch them closely, we rear them, we get them to the age of 5, and then we pat them on the head and get them onto the bus, and they're out in the wild, right, so to speak, right? And so a system of care would mean that we're sort of monitoring and watching and coaching wherever we're at throughout the system, and we're trusting that whoever we're handing off to knows how to take care of this child, right? So I go back to an interesting model that you have, Dr. Wynn, in your practice, where you're in a more open system in your environment, and you've chosen to have a really close relationship with a community pharmacy where some of their staff actually come to your practice, and you've got this interesting dynamic where you have some folks from the outside world in your practice, and you extend some expectations into the outside world from your practice. Can you kind of describe what that looks and feels like, and why it's so important for diabetes in particular?
Oh yeah, we have a model. We have a typical, fairly normal primary care practice with some specialty activities involved with HIV, et cetera. But we have an in-house pharmacy and a relationship with a pharmacy that actually extends to access to our charts. We send prescriptions there for review, for prior authorizations, for consults on the best choice for this patient. Sometimes it's based on insurance issues. Sometimes it's drug interactions and what's safest, or patients who have questions or concerns. One of the reasons, there's so many reasons that patients are non-compliant with diabetic care. They become afraid of this medication because they saw an ad from a lawyer looking for patients for this, or they had a hypoglycemic episode and they were very afraid of seeing that again, so they're afraid to take their insulin regularly. They don't understand how this one works versus this one works, and so having that many people who are knowledgeable about the process involved and the patient recognizes and has a relationship with is invaluable.
So it sounds to me like, so one, you have an appreciation for adherence. Solving the problem of adherence is not just reminding the patient to take their medication.
Not at all.
Right? That's a dramatically oversimplified intervention, right? So there's 1,000 patients, you got 1,000 different reasons why they're adherent, they're very patient-centric, and you might have 400 different interventions that are required in some way or shape or form that's patient-centered to solve for those 1,000 non-adherent events. What I hear you saying is that you've got a different level of expectation of the pharmacists and pharmacies that you work
feedback.
with.
I expect interaction and with the patient directly, but also with me, and feedback as to, have you thought about trying this? Or this happened with this, would you mind if we tried this? And
I mean, candidly, this sounds, you know, yesteryear was my responsibility, your responsibility, and what I hear you migrating toward is our responsibility.
Because we have the same goal, hopefully.
Which means you have expectations of that care team member that said, hey, I expect this of you because I need this for my measures, my professional fulfillment, my patients that need to get to goal. Tripp, what does that look like on the outside?
This sounds like the recognition of shared goals, which is the barrier we run into a lot in trying to work more closely with a lot of the providers in our area. Sometimes there's this disconnect that we've got the same goal that they have. We get this stamp a lot of times of being a dispensary. And that's not, you know, we actually share the same goals, and it's sometimes hard to get over that hump. We spend a lot of time there, and once you do, it's very rewarding for both sides. But you know, that unfortunately, that siloed piece of this is my care, this is my event, this is your event, and we're going to stay in our lanes. You know, unfortunately, that's reality right now in most situations.
And what I hear everybody saying, it's bad care.
Oh, well,
That doesn't work up
who
right
owns it?
now, right?
Fragmented
Who's got
care is
ownership,
bad.
right? And it all comes back to ownership. You know, this is what we're hearing here is a joint ownership of this patient. This is our patient, where what we see is just this really not very efficient handoff from event to event to event to event, and where if we can invest cardiovascular, let's say in diabetes, so we've got patients that come in regularly for medication optimization, right? Or how are you at goal? What's going on? What can we do better? New guidelines come out, makes us rethink what we're going to do at this point. Maybe it's more expensive in the short term. Well, in our current insurance mix, I mean, we're kind of on a 12-month budget. We're not really looking, so it may be expensive in this 12 months, but we may save hospitalizations, amputations. We may save all kinds of things 10 years down the road. So who's accountable for that? Obviously, the patient is, but we need to make sure that we're all focused on that. And so I know all pharmacies aren't you know where we are and what Dr. Wynn's seeing, but more and more are, and I tell our staff all the time, you know, when we go in and talk to provider groups, do in-services, and talk to folks, you know, the bar is so low right now for pharmacy expectations, it's dispensing. So when we go in to talk to a payer, we talk to a health system, we talk to a provider group, you know, I always tell them when we walk in, like, do we need to tell them about this? No, they're used to nothing. You know, they're used to no communication. So anything we offer is a plus, and then we can only build from there. And I think that's where we as a community pharmacy profession, we need to be better about going in and just building those relationships from the base, from the low.
So what I hear you saying is you walk in and say, expect more from me.
Exactly. Yeah.
Right? Expect more from me, and one of my goals is to help you get home on time, meet your metrics and deliverable on your performance, and ultimately improve your patients' lives.
Our patients.
Seems logical to me, right? So,
And I think it might be happening. I mean, you see in the news right now what's going on with someone like an Aetna and a CVS Caremark, and that's exactly what you described. If you can get everyone aligned in terms of the metrics and the financials make sense, then all of a sudden I think they're going to start caring. Right? Up until now, there just isn't that reimbursement, whether it's that community pharmacy level for those cognitive services. I mean, you guys run a remarkable pharmacy down there, but I could have other colleagues that would argue that, well, I'm being looked at and benchmarked for how many MTMs I do or how many immunizations I do.
Well, we
I
say
just
the same
don't.
thing.
Yeah,
Right.
I just don't have this
Yeah.
time, because you ask many of the pharmacists, all of them want more time to counsel, but they necessarily don't have it because that's not tied to any type of, you know, reimbursement or recognition of their cognitive services.
So